Hello, and welcome to the ASCO Daily News Podcast. I am your guest host, Dr. Diwakar Davar. I'm an associate professor of medicine and the clinical director of the Melanoma and Skin Cancer program at the University of Pittsburgh's Hillman Cancer Center. I'm delighted to have my friend and colleague, Dr. Jason Luke, on the podcast today to discuss key abstracts in melanoma and immunotherapy that will be featured and highlighted at the 2024 ASCO Annual Meeting. Dr. Luke is an associate professor of medicine, the director of the Cancer Immunotherapeutic Center, as well as the associate director for clinical research at the University of Pittsburgh's Hillman Cancer Center. You will find our full disclosures in the transcript of this episode. Jason, as always, it's a pleasure to have you on this podcast to hear your key insights on trials in the immunotherapy space and melanoma development paradigm, and to have you back on this podcast to highlight some of this work.
Thanks so much for the opportunity to participate. I always enjoy this heading into ASCO.
So we're going to go ahead and talk about three abstracts in the melanoma space, and we will be starting with abstract 9504. Abstract 9504 essentially is the Relativity 048 study. It describes the efficacy and safety of the triplet nivolumab, relatlimab, and ipilimumab regimen in advanced PD-1 naive melanoma. So in this abstract, highlighted by Dr. Ashiatu and colleagues, they report on the results of this phase 2 trial in this setting. By way of background, PD-1 inhibitors and immune checkpoint inhibitors starting PD-1 and CTLA-4, as well as PD-1 and LAG-3, are all FDA approved on the basis of several pivotal phase 3 trials, including Keynote-006, Checkmate 066, Checkmate 067, and most recently, Relativity 047. So, Jason, can you briefly summarize for this audience what do we know about each of these drugs, at least the two combinations that we have at this time?
For sure. And of course, these anti-PD-1 agents, of course, become a backbone in oncology. And in melanoma, we know dating back to more than 10 years ago now, that response rates in the treatment-naive setting to anti-PD-1 with either pembrolizumab or nivolumab are roughly in the range of mid-30s to high 40s. And we've seen clinical trials adding on second agents, and you alluded to them, the seminal study being Checkmate 067, where we combined a PD-1 antibody and CTLA-4 antibody, or Nivo plus Ipi. And there the response rate was increased to approximately 56%. And more recently, we have data combining PD-1 inhibitor with anti-LAG-3, so that's nivolumab and relatlimab. Now, in that trial, Relativity 047, the overall response rate was described as 43%. And so that sounds on a first pass like a lower number, of course, than what we heard for nivolumab and ipilimumab. We have to be cautious, however, that the cross-trial comparison between those studies is somewhat fraught due to different patient populations and different study designs. So I think most of us think that the response rate or the long-term outcomes between PD-1, CTLA-4, and PD-1 LAG-3 are probably roughly similar, albeit that, of course, we have much better or much longer follow-up for the Nivo plus Ipi combo. The one other caveat to this, of course, then, is that the side effect profile of these two combinations, of course, is distinct, where the incidence of high-grade immune-related adverse events is going to be roughly half with nivolumab and relatlimab, a combination of what you would see with nivolumab and ipilimumab. So that has caused a lot of us to sort of try to think about where would you use these different combinations. But we do see that all of these treatments can land a durable long-term response in the subset of patients that do have an initial treatment benefit. The landmark, I think, for the field has been the 7.5-year median overall survival that we've seen with PD-1 plus CTLA-4, Nivo plus Ipi. Of course, we don't have such long-term follow-up for PD-1 and LAG-3, but I think that's the setting for thinking about the rationale for combining a triplet regimen of PD-1, CTLA-4, and LAG-3.
So, Jason, in your mind, given the difference and the disparity in durability of the responses for the 067 regimen of Nivo-Ipi and the Relativity 047 regimen of Nivo-Rela, what is the standard of care in the US, and how does it change in the rest of the world, knowing that Nivo-Rela is not necessarily approved in all jurisdictions?
So this is a major complication in our field, is that there is perhaps not complete agreement across the world in terms of what the frontline standard of care should be. So I think most United States investigators or those of us that, really treat melanoma most of the time would suggest that a combination regimen, given the enhanced response rate and longer term outcomes, should be the consideration for the majority of patients. In fact, in my practice, it's hard to think of who I would treat with a monotherapy PD-1 approach in the PD-1 naive setting. So either Nivo plus Ipi or Nivo plus Rela. As you alluded to, however, in other regulatory settings throughout the world, combinations might not actually even be approved at this point. So PD-1 monotherapy would be the backbone of that setting. So it does set up some complication when you think about a comparator arm. Say you were going to look at various combinations. Probably PD-1 monotherapy would be the worldwide comparator. Have to understand, though, in the United States, I think that's a less attractive option.
So in Relativity 047, Dr. Ashodo and his colleagues are looking at potentially a triplet. And in this case, they looked at this in the context of frontline metastatic melanoma, 46 patients. Very interestingly, the dose of ipilimumab studied here was 1 milligram per kilogram Q8 weeks, not the 3 mg per kg every 3 weeks times 4 doses used in 067, or even the low-dose ipilimumab regimen that you studied in the second-line setting, which was 1 milligram per kilogram every 3 weeks for 4 doses. So let's talk about the results and specifically the implications of potentially studying lower doses of ipi.
Yeah, so I appreciate you raising that point. I think it's really important as we think about this data set, because this triplet regimen is not by any means the only version of a triplet that could be developed using these agents. So just to give the high level numbers from the abstract, we see from these data that the overall response rate is described as 59% and 78% a disease control rate, with patients having an unreached length. So duration of response of unreached, and then the progression-free survival at about 5 months. So those are really interesting data, but as was alluded to, it's not totally clear to me that that's the best that we could do with this regimen. Now, you alluded to this low-dose ipilimumab schedule at 1 milligram per kilogram every 8 weeks. And it's really important to note that we have no benchmark for that regimen in melanoma oncology. And in fact, the one study that used that regimen, which was the adjuvant study of nivolumab and ipilimumab, known as Checkmate 915, is in fact the only immune checkpoint inhibitor study in melanoma oncology that was actually negative. So that study noted no benefit to adding ipilimumab at 1 mg per kg every 8 weeks on top of nivolumab, again, the adjuvant setting. So it's a little bit curious to then understand what it means in this study to have that amount of ipilimumab added to the Rela-Nivo backbone. And that manifests in a few different ways. We see the response rate here at 59%. Again, if you compare that just against the standard Nivo plus Ipi dosing schedule, it's about the same. So is that really an advantage to having the triplet as compared to just doing standard Nivo plus Ipi? We do see that it does manifest in a slightly lower rate of grade 3-4 immune-related adverse events at 39%. That's a little bit lower than what we'd expect for standard Nivo plus Ipi. But again, I think that emphasizes to me the possibility that some efficacy was left on the table by using this very low-dose ipilimumab regimen. And so I think to me that's really a concern. It's not clear to me that these triplet data really differentiate from what we'd expect with the already approved regimen of Nivo plus Ipi. And so therefore, it makes it difficult to kind of think about how would we really want to move this sort of regimen forward, or should there be more work done about dose and schedule to optimize how we might want to do this?
So as far as triplet therapy in the context of frontline metastatic melanoma, meaning triplet immune therapy, because there are at least several targeted therapy triplets that we, at least FDA approved, not necessarily widely utilized. How would you summarize the future for triplet therapy? Do you think it's potentially attractive? Do you think it's very attractive with some caveats?
Well, I think it's attractive, and we have 3 independently active agents. And so I do think it's a priority for the field to try to figure out how could we optimize the therapy. We've had such a revolution in melanoma oncology, talking about 7.5-year median survival from Checkmate 067, but that still implies that 7.5 years, half the patients have passed away. There's more to do here. And so I do think it should be a priority to sort this out. I guess I would be cautious, though, about advancing this regimen directly to a phase 3 trial, because it doesn't seem clear to me that this is optimized in terms of what the outcome could be. If we're willing to tolerate higher rates of toxicity from other dose schedules of Nivo Ipi alone, then I think we should do a little bit more here to potentially explore the space that might be possible to increase that overall response rate a little more, without getting into a completely exaggerated toxicity profile that would be unacceptable. So I do think it's exciting, but possibly more to do before really thinking about going big time with this.
Great. So now we'll switch gears and move from frontline metastatic melanoma to the second line and beyond, looking at a new agent and contextualize the effects of that actually in the frontline setting. So abstract 9505 describes the efficacy and safety of lifileucel, which is essentially autologous tumor-infiltrating lymphocyte cell therapies, also known as TIL, in combination with pembrolizumab in patients with ICI naive, so not necessarily pre-treated, but ICI naive metastatic or unresectable melanoma. And this is data from the Iovance COM202 cohort 1A, oral abstract presented by Dr. Thomas and colleagues. So in this abstract, Dr. Thomas and our Iovance colleagues are presenting data from the 1A cohort, which is the phase 2 portion of the frontline trial that is evaluating autologous TIL with pembro in checkpoint inhibitor naive metastatic melanoma. By way of background, TIL is FDA approved on the basis of several cohorts from a phase 2 trial. The data has been presented multiple times now by Drs. Sarnaik, Chesney, and multiple colleagues of ours. And essentially, autologous TIL, which is generated from a surgical procedure from which a patient undergoes a surgery to extract a tumor, from which T cells are then grown after ex vivo expansion and a rapid expansion protocol. The entire procedure that was essentially pioneered by several colleagues at the NCI, primarily Dr. Steve Rosenberg. And this approach produces objective response rates of approximately 31 to 36%. And the most recent publication demonstrated that at median follow-up of approximately 2 years, the median duration of response was not reached. The median OS was about 14 months, and PFS was about 4 months or so. So can you contextualize the results of the abstract in the frontline setting? And then we'll talk a little bit about where we think this is going to go.
So I think this is a timely study given the recent approval. And in the abstract presented here, we see an early data cut from the PD-1 naive study, as you alluded to. So here we had 22 patients and distributed across various states of advanced melanoma. 10 out of the 22 had M1C, but there also were a smattering of earlier M1A and M1B at 18.2 and 9.1%. So this is important as we think who the treatment population is that's going to be optimized with a TIL procedure. The median sum of diameters, meaning how much tumor burden the patients have, was about 5.5 centimeters. And I'll note that that's relatively modest amount of tumor burden, albeit not that unusual for an early stage trial. So of the patients that participated, 8 had BRAF mutations. So that's 36%. That's not that high, but it's a reasonable. And I think the important overlying number, the response rate so far in the study with about 17 months of follow-up was 63.6%. And that includes 22% or 23% having complete response. So those are interesting data. And another point that was made in the abstract, which we've all seen, is that responses to TIL, but all of immunotherapy, but especially TIL, do seem to mature over time, meaning they deepen over time. So it's possible the response rate could go up to some extent as we watch this study advance. So I think these are exciting data on some level. Also, worth sort of a consideration on another, which is to say that, a 63.6% response rate, that sounds pretty impressive. But we do have to put that in the context of doublet checkpoint blockade, which we just got done discussing, gives you almost a 60% response rate, 59% response rate. So the question really then is it worth the amount of effort that would go into generating a TIL product in a treatment-naive patient and put them through the lymphodepletion that is associated with TIL and the high-dose interleukin-2 treatment that accompanies the reinfusion of the TIL, if you're going to get a response rate that's roughly the same as what you would get if you gave them off-the-shelf Nivo plus ipilimumab. And so it's a little bit at this point hard to know the answer to that question. I think it could be possible that the answer is yes, because we don't know exactly which populations or patients are most likely to benefit from each of these therapies. And if it could be teased out who's not going to benefit to Nivo plus Ipi from the get-go, then of course we would want to offer them a therapy that has that frontline potential, durable long-term response. But I have to say, on a one-to-one with TIL therapy, you get a lot of toxicity initially with the treatment. With Nivo plus Ipi on the back end, you get a fair amount of toxicity with the treatment, right? So, how are we going to judge those two things? And I think we probably need a larger data set to really have a good handle on that. So these are interesting early data, but it's not totally clear to me that even if this holds up all the way through the trial, and we're going to talk about the design of the registration trial here in a second, a 60% response rate on its own without further biomarker stratification is a little bit hard for me to see in clinical practice why we would want to do that, given we can already just go off the shelf and give checkpoint inhibitors.
So that brings us to TILVANCE. So TILVANCE is a phase 3 trial. It's a registration intent trial by our Iovance colleagues evaluating the pembro-TIL regimen versus pembrolizumab alone. So in this phase 3 trial, approximately 670 patients will be randomized to either Arm A, which is lifileucel plus pembro. And in this Arm A, patients are going to be getting lifileucel, with the tumor resection, non-myeloablative lymphodepletion, the lifileucel, an abbreviated course of high-dose IL-2, and after that, continued pembrolizumab, followed by continued pembro for the study mandated duration, versus Arm B, where patients will be getting just pembrolizumab monotherapy per label. Arm B patients, per the design, may cross over to receive TIL monotherapy at the time of central blinded radiology confirmed disease progression. The study design otherwise is fairly routine, and per most of our registration trials these days, patients may have actually be permitted to receive neoadjuvant and adjuvant therapy, including checkpoint inhibitors, as long as the receipt of the therapy was more than 6 months prior to the inclusion of the patient in that registration trial. The dual primary efficacy endpoints are stated BICR-assessed objective response rate, as well as PFS, and the key secondary endpoint is overall survival. So, Jason, what are your thoughts on the study design and potentially the regulatory implications, particularly given, one, the control arm of pembro monotherapy, and two, the role of TIL crossover to receive TIL monotherapy at the time of BICR-mandated progression for Arm B?
So this goes to a few points that we've touched on already in the discussion here. When we think about the primary endpoints for this study, with one of them being overall response rate, one has to kind of assume that that's a given that they would get that. I kind of feel like that's a low bar. And we go back to that comparison, cross-trial comparison. If their results end up being that the response rate's about 60%, I don't know that that differentiates necessarily from what's already available in the field with combination immune checkpoint blockade. For the purposes of the study, that would mean it's a positive study. So I think that would probably be good. But again, the comparator to a pembrolizumab monotherapy, I think some of us would argue isn't really consistent with what we would do with a patient in our clinic. So it's not that it's bad per se, but I think there's going to be a whole lot of cross-trial comparison. So if the study is positive, that would be good for getting the drug available. It's still a bit hard, though, based on the preliminary data that I've seen, to imagine how this would have uptake in terms of utilization as a frontline therapy. You alluded to the crossover, and I think there the assumption is that patients who get TIL therapy as a second line perhaps would have an attenuated benefit, but I'm not sure that's really true. It certainly looks from the data that we have like the patients who benefit the most from TIL are going to be those who didn't respond to anti-PD-1 in the front line. So I'm not sure how much difference there's going to be between first and second line TIL therapy, but those data will kind of wait to be seen. So I think it's an important study. Of course, the accelerated approval of TIL as a later line therapy is dependent on this trial being positive. So there is some risk that if this trial ended up not being positive, that could have regulatory implications on the utility or availability of TIL as a subsequent line therapy. But all of these, I guess, we'll have to wait to see the results. We do hope for a positive trial here, although I think it'll be nuanced to sort of interpret those data, given that pembrolizumab monotherapy control arm.
Fantastic. So we've learned a lot about TIL, both its use in the second line setting and this very exciting but potentially risky frontline trial that is ongoing at some centers in the United States and certainly a lot of ex-US enrollment. So we'll now pivot to a related product, which actually belongs to a much larger class of agents that are antigen-specific T-cell therapies in a variety of different formats. And that is Abstract 9507, which is the phase 1 efficacy and safety of IMC F106C, a PRAME CD3 ImmTAC bispecific in the context of post-checkpoint cutaneous melanoma. Now, in this abstract, Dr. Omid Hamid and colleagues report on the results of this phase 1 trial. As a disclosure, I'm an investigator and the last author on this manuscript. And Jason, it'd be important for our audience for us to maybe firstly outline PRAME as a target and then the ImmTAC as a platform prior to discussing these results. So let's start with the target, PRAME, which I think is a target that you know fairly well. So why don't you start with the target and we'll talk a little bit about that and then the platform.
Yeah. So I think for the audience, being aware of PRAME, or the preferentially expressed antigen in melanoma, is going to be quite important moving into the future. So PRAME as a therapeutic target is a cancer testis antigen that's overexpressed in tumor tissues. And of course, the name has melanoma in it, but it's not a uniquely present in melanoma. So the expression patterns of PRAME as a target are very high in melanoma. So in cutaneous disease, this is upwards of almost 100%, somewhere between 95 and 100% in metastatic melanoma tissues. And PRAME has several different roles on a molecular level, although I don't think for our purposes here, it's so much important to be aware of them, but rather that this is a very highly expressed target, which then can make it attractive for using T-cell receptor-based therapies. And so in the case we're talking about here on the ImmTAC platform, that's a CD3 by PRAME bispecific approach. But of course, there are other approaches that can also be taken, such as TCR T cells that are directly go after PRAME itself.
So let's now talk about the platform and how it differs from some of the other antigen targeting platforms that you have just alluded to. So I think the ImmTAC platform is basically a fusion protein comprising engineered TCRs with a CD3 specific short chain variable fragment. And then the engineered TCR, therefore binds antigens in an HLA dependent fashion. But you know quite a lot about some of these alternative platforms. And I think it'll be important to contextualize for audience the difference between ImmTAC, which there is a prototype drug that is already approved in the context of tebentafusp. But how does this differ from some of the other more nuanced platforms, such as the Immatics TCER or TCER platform and TScan's TCRT nanoplasmid platform?
Right. So the ImmTAC platform, as alluded to, is already approved on the market with tebentafusp, which is the GP100 by CD3 bispecific molecule. And the advantage of that approach is infusion off the shelf of a drug. The downside of it is that it is a weekly dosing strategy as it stands now. And there are some complicated disease kinetics associated with treatment response, which we'll come back to in the context of the PRAME bispecific. Those are in contrast with T-cell receptor transduced T cells as an alternative strategy, which is a form of adoptive cell transfer. So we just got done talking about TIL therapy, which of course is trying to take lymphocytes out of the tumor and grow them up and then give them back. Here with TCR transduced T cells, we're talking about taking leukopak from the blood and then using different transfection approaches to try to insert into the lymphocytes of the patient a T cell receptor that recognizes to a certain cancer antigen, and in this case, PRAME. So you alluded to a couple of different companies that have different platforms to do this. Immatics has a molecule called IMA203, for which there have been data disclosed in the past year, again, showing some very interesting responses in patients who have highly refractory melanoma. That process, though, again, does require lymphodepletion before you reinfuse the cells. So again, in contrast to the ImmTAC, which is an off-the-shelf drug you administer, there you have to make the product and then bring the patient back, lymphodeplete, and give the cells back. Immatics platform uses a viral transfection vector. The TScan approach that you alluded to before uses an approach of a mixed system on multiple HLA backgrounds to try to get past HLA A201 only. And in this case, uses a plasmid-based transfection syndrome that perhaps can be more broadly utilized given the lack of a lentiviral vector. So this is a complicated area of technology that starts to get into immune engineering. And I think for the purposes of this discussion, we don't want to belabor it. But both of these technologies, talking about the CD3 bispecific with the off-the-shelf aspect of it and the adoptive cell transfer, each of these using a T-cell receptor-based therapy to try to go after PRAME, I think have very high upside. And I think we'll initially see it in melanoma over the next year or so, but this is likely to be relevant to multiple tumor types beyond melanoma.
So let's discuss the results of this phase 1 trial. The IMC F106C, like all other ImmTACs, is administered intravenously and does require step-up dosing. You alluded to the fact that tebentafusp was approved, and it's one of those drugs that is fortunately otherwise administered weekly, which can be difficult for the patient, and requires at least the patient spend the first 3 doses overnight under some kind of monitoring, whether it's in the hospital or extended outpatient monitoring for at least 23 hours. The efficacy of this agent and this platform appears to be surprising in that you tend to see a relatively low RECIST response rate. We'll have you comment a little bit on why that is the case. and what might be the role of ctDNA as opposed to conventional RECIST in assessing response. At least in this trial, they mandated PRAME testing but did not require it for study enrollment. And PRAME positivity was defined using immunohistochemistry with a relatively low H score of 1%. And the molecular response definition was a 0.5 log, or a 68% ctDNA reduction just prior to the first imaging assessment. So how do you contextualize the results? But maybe before you talk a little bit about the results, the ctDNA aspect, that was a recent publication by Rich Carvajal, Alex Shastari, and I think you also involved in that.
So I think an interesting observation around tebentafusp has been that ctDNA may be a better predictor of long-term outcomes. And how you define ctDNA response is still something that the field is grappling with, albeit that I think is going to be an important consideration as we think about these novel therapies, these ImmTACs, and other CD3 engagers moving into the future. But for the purposes of the abstract here, we see that in the population of patients treated, there were 46 patients with cutaneous melanoma. The majority got monotherapy with IMC F106C, and that's the PRAME bispecific. So 40 patients that got monotherapy and 6 who got a combination with checkpoint inhibitor. All these patients had prior treatment with immunotherapy, and most of them had PD-1 and CTLA-4 antibody, with a small smattering that also had BRAF inhibitors. In terms of that PRAME testing that you alluded to, based on the immunohistochemistry H score greater than 1%, 35 out of 40 patients were positive, so they defined 5 as negative. And we could come back to if we have time, but there are other ways to do PRAME testing as well that I think may become unique for different agents, maybe an important biomarker. In the data, 31 out of the 46 patients were RECIST evaluable, and the outcomes of those patients were to note that the response rate was 13%, which was 4 partial responses, but 35% of patients had tumor regression with a disease control rate at 65%. It was clear that there was an enrichment by PRAME positivity for both progression-free and overall survival. So those patients who had obvious positivity essentially had a doubling of the PFS and more than a doubling of the OS, so 2.1 to 4.1 months for PFS and landmark OS 40% to 94%. So I think these are quite intriguing data. It does suggest that for the vast majority of patients, we do see some induction of anti-tumor effect, albeit that RECIST might undercall the effect. And so this may become another area where the ctDNA monitoring might be able to help us to understand who is likely to have really long-term benefit from this therapy. And given the number of emerging treatments that we have for melanoma, we might be able to really focus in on that group of patients in terms of optimizing how we would use this drug moving into the future.
So, you talked about a response rate, and, at first glance, this response rate is a little underwhelming, right? Like, we're talking about 4 out of 31 RECIST evaluable patients, 13%. So it's in the double digits, but barely. So how enthusiastic are you about the results? How does it contrast with at least the publicly known data from other PRAME targeting approaches, such as the IMA203 agent? Understanding that while they may be all targeting somewhat the same target, they're actually extraordinarily different platforms. One's off the shelf, one's highly customized. How do you contextualize the results? How would it contrast with other cellular approaches?
So I think it's important, again, to emphasize the point you made, which is they're very different kinds of treatments. So despite the fact that they both target PRAME, they're going to be differently useful, and they could be quite useful for different groups of patients. And so here we see that there is a subfraction of patients who are deriving long-term benefit. And we commonly have an argument in our field about, is overall response rate really a useful moniker that describes a patient-centric outcome? While, of course, patients like to know their tumors are shrinking, what they want the most is for the tumors not to get worse and for them not to pass away from cancer. So I think I'm enthusiastic about these results, but emphasizing the point that we need to better understand who's going to benefit the most from this CD3 bispecific PRAME approach and how we're going to be able to harness that into long-term benefit for patients. Because there's no doubt that an off-the-shelf therapy has a high degree of value relative to adoptive cell transfer, which sort of requires a big windup. So when you say, what does it contrast with? Well, the data for IMA203 has shown more than a 50% response rate in patients with more than 5 lines of therapy for metastatic disease. So that really looks quite exciting. And several of those patients are now out for quite an extended period of time, meaning 2 years or more, given only a single dose of IMA203. But again, the caveat being, you have to make the cell product for the patient. That takes time. You lymphodeplete the patient. Not all patients can tolerate that in a refractory disease setting. and then they have to be able to tolerate the reinfusion of the cells. And so this drug, IMC F106C, looks very promising. It's moving into earlier phase trial that we'll talk about. I think the TCR T-cell program has a lot of upside for patients, especially with refractory disease. And so I think these two different approaches are really on parallel tracks. They both target PRAME, but I don't think they necessarily need to be compared one-to-one as if they're going to go head-to-head with each other.
So now we'll talk a little bit about the frontline setting, because on the basis of some of these results, Immunocore is now exploring IMC F106C in frontline melanoma. This trial is actually being presented as a trial in progress at this meeting by Georgina Long and colleagues. Some of us are co-authors on that abstract. And in this study, HLA-A2/O2/1 positive patients with advanced unresectable melanoma will be randomized 1-to-1 to the combination of IMC F106C, which actually I think after this meeting will be known as Brenni, in combination with nivolumab versus nivolumab regimens, which will either be Nivo or Nivo-Rela. It's investigator's choice and likely dependent on region. So what do you think of the challenge of this trial? We talked about some of the challenges of the Tilvans trial earlier, but what is going to be the challenge of this trial? And in this setting, particularly given the response rates that we've seen so far?
Yeah, so similar to comments we had before, thinking about what the optimal control arm is for a study like this is difficult. And so that'll be important as we think about interpreting the results. So one has to assume for the purpose of this conversation that it is a positive trial and that adding the PRAME bispecific here does lead to an improvement in progression-free survival relative to those immune checkpoint alone approaches. And so I think the magnitude of that difference is going to be of some relevance. And then I think importantly also figure out who needs this treatment and who's going to benefit long-term are going to be just really important considerations. We alluded to how the drug requires an intensive dosing period at the get-go. And so telling patients that they need to come in weekly or biweekly initially for some number of weeks before they switch to a longer-term intermittent regimen, that comes with real-world considerations for patients, their families, their finances, et cetera. So the benefit has to be clearly obvious that makes it worthwhile doing that. Again, because a default could be giving drugs that we've had for 10 years with nivolumab and ipilimumab. So there's going to be a lot of cross-trial comparison that is going to necessarily have to take place here to think about what do these results really mean in the context of other available therapies. I think the study is reasonable to do. I think this is a very active agent. There's no doubt there's a subset of patients who seem to benefit a lot from it. And I would just emphasize the point that that's probably going to be the most important thing to really drill down on is under the assumption there's a positive trial, we need to know who those people are so we can optimize giving this kind of a treatment to them.
I guess one important point to underscore what Jason said about potential predictive biomarkers, I think as part of the presentation, Dr. Hamid and colleagues will be talking about a candidate predictive biomarker of this agent, which is potentially class-specific and not necessarily agent-specific, of a T-cell signature that potentially could define patients who are more likely to benefit to this agent. So Jason, as always, thank you for sharing your expertise and insights with the team today. We certainly look forward to catching up again for our wrap-up episode after the annual meeting, where we'll talk about some of the data that we could not talk about, particularly the late-breaking abstracts, and other key advances that will shape the future of certainly the field of immunotherapy and melanoma, but potentially the field of cancer immunotherapy writ large.
Oh, thanks very much for the opportunity.
And thank you to our listeners today. You'll find the links to the abstracts discussed today in the transcript of this episode. And finally, if you value the insights that you hear on this podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. So thank you, and we'll see you soon.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.